After this treatment, there were follow-ups with the parents and plans together with them for making the information to the school, and just to discuss what he had succeeded in treatment and so on, but also different words about how to continue and so on. So we had a school meeting, and it was information on treatment results, exchange of information also from the speech language therapist in school, and joint planning. And we saw that there are future needs more speech training for marching, and hopefully, if I can get along and have a group with other children who stutter at the same age, that would be wonderful, just what he needs. And here Martin, that's his favorite. His dream is to have fun and play football like Ronaldo, the famous Portuguese. But here I will make a summary of Martin. As you remember, he was a complex case, a bilingual child where a mild stutter rapidly had developed to selective mutism, affecting his overall possibilities to communicate with adults. In this situation, Martin came to a situation of freezing, and we saw a tendency of it at the first recording before treatment, but it was even more than that. So, but for ethical reasons, I didn't show all these. He had long silent blocks, he had vocal struggle converted to silent blocks. The very first commitment for me as his speech language pathologist was a trial to make him overcome this state of selective mutism through easy communication with help from his younger brothers. Before making this decision, I had consulted a psychologist in general terms and had consistently a possibility of referral to him if the process wouldn't work out for Martin. This was also discussed with his parents. Another reason for me to judge if I could be able to handle this case were the experiences and knowledge built up during the last years of teamwork with children with neuropsychiatric disorders at the rehabilitation center, and that's a child rehabilitation center here. And the goal for the first 10 clinical visits was to make Martin comfortable in communication with me and with his parents and other adults at home, slowly through a consistent preparation to back off when needed and let his younger brothers play with him. It succeeded, so I was very aware of will I be with him or back off? At the appointment time after Christmas holidays, I suddenly saw a happier child prepared to work with his speech. By the end of treatment, I see a happy child, a boy that has got rid of his shyness and sometimes making jokes. We have to remember that this was succeeded through cooperation with the parents and his brothers. The speech training became short, only 10 appointment times. This was not enough to make the final change to his speech pattern. Today he has a mild stutter with most of the blocks reduced to quite gentle repetitions. We hope that Martin will have the opportunity for a 1-week intense speech training program, together with other children at his age that stutters. The primary goal of this intervention is, through increased fluency in speech, make him and his peers more fluent in life. Working together with other children in the same situation makes the training enjoyable and, accordingly to our experiences, hindrances to future relapse. The learning outcome accordingly to Korthagen that I mentioned in the beginning, the pedagogy issues, and we have to make some reflections here, and I have to make some reflections on my own. Okay, I worked very steadily with him and his brothers. He overcame the first difficulties before Christmas, and he enjoyed the speech training. And we saw a much more happier boy at the end of the post-treatment recording. But anyhow, am I proud of every step that I have been taking in this process of assessment and treatment of this boy? Or is there something I would have changed or made undone? And here I have some concern regarding what I did and the episteme, the theory with the big T, or the phronesis, the clinical practical knowledge, the theory with a small t. Is there something that would have changed to made undone? In Swedish we have the expression magkänsla, and that means a feeling of stomach trouble. This doesn't feel right to do, but I'm doing it, or I have to do it anyway. In this case, it was a clinical trial and an evaluation of different assessment protocols as a part of the education. Some of them felt beneficial for Marcin and the evaluation of his progress in treatment, but others not. The concern I have of not feeling right to do is the behavior checklist, the BCL, where you actually confront the child with his privacy by asking him directly what kind of movements he makes with his body when sounds are difficult to say. As we know, bodily movements mostly occur during occasions like expectancy to stutter or during the stuttering moment. This is generally referred to concomitant behavior. In Marcin's case, I actually asked him directly if he wrinkled his nose before speaking, a fact that he might be aware of or maybe not aware of that he actually did. Confronting him directly with this questionnaire at the beginning of therapy, the consequences became another 2 clinical visits before he could start to be open for communication with me again. He got very sad. He didn't like this at all. Thanks to his brothers, he could overcome these difficulties. By the end of therapy, when given again the same questionnaires, I had to apologize him by asking these questions again, explaining it as a clinical evaluation procedure, not to do with him, and give him a reward afterwards. And then it was okay. This highlights Korthagen in another way as well, the phronesis or the procedural knowledge, the theory with a small t, that might be in conflict with the episteme, the theory with the big T. Why were you doing this, Helena? What major concerns was the most obvious for you at that moment? The episteme or the phronesis? Could you have made this otherwise? What have you learned from this? What consequences will this situation of learning have to your future approach in your clinical work as well as your clinical research? In that particular moment, my major concern was the theory, the episteme. I wanted to explain Martin's difficulties in terms of the demands from holistic theory, where all parts of his stuttering behavior has to be revealed and brought into open. The behavior checklist is a part that concerns to reveal his coping behavior, behaviors to cope with the anticipation or presence of speech disruption. Could I have made this otherwise? Yes, I think so. In a clinical situation like this, there are needs to consider which way of approach that might be the most ethical and efficient in reducing disturbing or negative behavior. The two approaches I'm referring to is confrontation vs fading. When you're using confrontation, that should mean that you in therapy find it useful or helpful of commenting such as "Stop wrinkling your nose otherwise," or "Why are you wrinkling your nose like that? Is there something else you can do instead?" A change of behavior. The other way of solution might be fading, where you do not pay attention to this behavior, making it pass through. Using fading, the approach should be applying possibilities for a more adequate change of behavior by his own. When a coping behavior is no longer useful or important, in most cases it fades away by itself. One solution is providing the client the opportunities for a more fluent speech. The experiences for me as a clinician, by viewing all pre-post treatment recordings, is that I have seen most of these coping behaviors faded away when my clients feel the self-esteem of fluency in speech. In this case of Martin, viewing the post-treatment recording in comparison with his pre-treatment expressions, this fact became more than obvious. This case of Martin made me realize the importance to keep the phronesis or the clinical experiences in the first place, and through mutual learning share these clinical experiences with others by empirical studies. In theory of stuttering, is theory of stuttering useless then? No, but a theory has to be built on empirical studies with evidence-based data. By doing so, we will move forward, bridging the gap between research and clinical practice. In this way, old theories built on something else than empirical data will no longer be of importance. Using this perspective, these theories will then fade away by themselves without any needs for dramatic paradigmatic changes, and be replaced by other theories supported by evidence-based clinical data. And here are the reflections, the final, and here is a beautiful picture of the old cathedral in Krakow in Poland and the museums. So being reflective is that is a process of lifelong learning. So we shall always reflect on what we're doing, but not being scared or not trying to do things, but then we have to be reflexive at the same time. Thank you for listening. Good night.